Hello, today we will study the pathophysiology of CRBSI, catheter related bloodstream infection with sepsis with underlying ESRD, DM, and hypertension. This patient is 64 years old and he come to hospital for hemodialysis, and after hemodialysis he developed high fever around 39 degrees Celsius. After hemodialysis he have productive cough with no diarrhea, vomiting, abdominal pain and dysuria. So let's go through pathway of DM first, hypertension, and then ESRD, and then and then CRBSI, and last sepsis. This patient he has risk factors such as sedentary lifestyle, excess sugar intake, family history, and his age 64 years old. And in hyperglycemia there is two pathways in which patient can have high sugar level. The number one, this pathway is called type 1 diabetes, and in this the patient will have beta cell dysfunction, and this beta cell dysfunction will produce impaired insulin. When there is production of impaired insulin, there will be desensitization of liver to level of glucose. It means the liver will not respond appropriately to the level of glucose, especially high sugar level. And therefore there is continuous release of glucose. When there is continuous release of glucose, there is high sugar. And another pathway is we call type 2 diabetes, and in this pathway there is decreased sensitivity to insulin, but the insulin is normal. Insulin production is normal, but patient have decreased sensitivity to insulin, and the glucose is unable to enter cells and it remains in the body, and there is increase in sugar level. And medical term for increased sugar level, we call it diabetes or hyperglycemia. Hyper means high. And in hyperglycemia there is non-enzymatic glycation of proteins. This means usually the glucose they bind to insulin and glucagon, but in hyperglycemia this glucose will bind to protein, and there will be formation of AGE. We call it advanced glycation and proteins, and this AGE formation dysfunctions destroys the function of endothelial, and when there is endothelial dysfunction there is overproduction and reduced degradation of ECM, overproduction and reduce ECM degradation, and this is called basement membrane thickening. And for now we will move to another pathway for hypertension. This patient have uh, same risk factors, except he has increased salt intake, and these factors are responsible for physiological changes such as increase in blood viscosity, change in arterial bed, and vasoconstriction. These three are called physiological changes. And these physiological changes are responsible for increase in vascular resistance. When there is increase in resistance, there is decrease in afterload, and the blood flow to organs are reduced. When there is blood flow, there is increase in blood pressure, and this blood pressure is responsible for activation of JG cells in two pathways. Number one is it reduces the renal perfusion, and number two is there is activation of beta receptor action. When there is activation of JG cells, there is also two pathways. Number one is we call it RAS system, and number two is there is a vasoconstriction. For number one, when there is activation of RAS system, there is increase in secretion of aldosterone and ADH or vasopressin, and ADH is responsible for reabsorption of water, whereas aldosterone is responsible for absorption of sodium. And when there is increase in reabsorption of both water and sodium, there is increase in plasma or extracellular fluid. And the other pathway is activation of JG cells leads to arterial constriction. When there is constriction, there is increase in peripheral resistance. So these two pathway leads to our diagnosis for this patient, hypertension. And in high blood pressure, it the blood pressure, high BP causes the injury to endothelium, and when there is endothelial injury, there is a like a hole, and when there is hole, there is increase in permeability, and this permeability increased leads to deposition of hyaline. This hyaline deposition is from two pathways, one from hypertension and other from DM. This hyaline deposition causes arteriosclerosis, which leads to hardening of glomerulus. This glomerulus follows the pattern such as this arteriosclerosis. We call it glomerulosclerosis. In glomerulosclerosis, there is decrease in blood flow. When there is decrease in blood flow, there is ischemia. Ischemia means less oxygen. This leads to tubular. The tube of kidney, they get atrophy. Atrophy means decrease in size. So in decrease in size, in compensation for that, the kidney they form fibrosis. In doing so, there is loss of nephron. So nephron is the functional unit of kidney. So when there is loss of functional unit of kidney, there is decrease in glomerular filtration rate. So this, when there is decrease in glomerular filtration rate less than 90, we call it CKD. But the last stage of CKD is ESRD, which is less than 15. So in this patient, he have 8. So he is in 5th stage of ESRD. So this patient has kidney and kidneys cannot function. So he undergoes hemodialysis at jugular vein. So there is a presence of palm cat at jugular vein. So when there is presence of palm cat, there is a break in skin barrier. This break in skin barrier serves as an entry point for gram-negative bacilli, and these bacteria, they colonize the surface of catheter, and they produce biofilm to protect themselves from antibiotics, and this leads to local infection, and the patient will exhibit signs such as redness, swelling, and sometimes discharge from palm cat, and this bacteria, they spread to bloodstream. This is systemic infection, and when bacteria spread to bloodstream, they are called CRBSI, catheter related bloodstream infection. So the next step of infection is sepsis. So now let's go through nursing diagnosis. Number 1 is he has a risk for septic shock because he already has sepsis. So nursing care for this patient with risk for septic shock is to administer antibiotics such as meropenem. The doctor order 500 mg, and another is levofloxacin, and we need to keep the mean arterial pressure above 65, and we will monitor lactate, CBC, and vital signs. We need to monitor especially lactate because increase in lactate indicates decreased tissue perfusion. And let's go to the other diagnosis, risk for fluid volume overload. So in end-stage renal disease, there is decrease in excretion of water and sodium, but this water and sodium, they remain in blood. So there is increase in plasma or ECF, and this leads to risk for fluid overload. So nursing care is to administer furosemide, and they are diuretics, and spironolactone. And in severe cases of fluid overload, there will be fluid can travel to lungs, and it will cause impair in oxygenation. Therefore, it is important to administer oxygen in fluid overload patients and restrict sodium and fluids. And next pathway or next nursing diagnosis is risk for bleeding. The kidney, they produce cofactors that are responsible for blood clotting. But in ESRD, there is decrease in production of cofactors, which leads to a risk for bleeding. And in ESRD, there is accumulation of uremia, which means the kidney cannot excrete waste products, and this uremia leads to dysfunction of platelet. Then thereby the platelet cannot adhere and aggregate to form the platelet plaque, and the problem is he can have risk for bleeding. So we need to administer coagulant, vitamin K, and stop administering anticoagulant. And we need to follow bleeding precautions, such as using small little and using a soft toothbrush like that. The next pathway is he has decreased cardiac output. So this has two pathways, one from erythropoietin and from uremia. This uremia decreases the lifespan of RBCs, and it directly leads to anemia. And kidney is responsible for production of erythropoietin, and this leads to, when there is decrease, there leads to anemia. In anemia, there is decrease in oxygen carrying capacity of RBCs, and where there is increase in cardiac output. So increase in cardiac workload, and where patient will have problem decrease cardiac output. So therefore we need to administer ferrous fumarate to correct the anemia first, and we need to promote race and monitor lab. And in end-stage renal disease, there is decrease in excretion of potassium. So the potassium remains in bloodstream, and we call that hyperkalemia. And the patient with hyperkalemia, they exhibit cardiac arrhythmia. Therefore, it is important to monitor potassium level. Therefore, we need to monitor EKG first, and we need to administer 50% glucose with regular insulin 10 units and calumet. And in hyperglycemia, there is persistent increased level of plasma glucose level. This leads to increase in plasma osmolality. This means they have increased concentration of sugar, sodium, and other molecules. And this high osmolality, they pull water out of cells into blood, and it leads to cell dehydration, because pull water out of cell. And as a compensation method, the kidney try to excrete the excess sugar or glucose but in doing so they also excrete water along with glucose, and this leads to severe dehydration, especially in brain. And when there is brain dehydration, it leads to neurologic impairment such as confusion, lethargy, seizures, and coma. One of the if the patient have sugar level more than 600 mg over dl, the patient will have HHS, hyperosmolality, hyperglycemic state. In this, patient will exhibit signs such as severe dehydration and hypervolemic and electrolyte loss. Therefore, in this patient, it is important to monitor neuroscience because there is dehydration in brain and exhibits signs such as confusion, lethargy, seizures, and coma. And in HHS, it is important to consider fluids first before insulin. Therefore, we need to administer isotonic solutions such as 0.9% sodium chloride, and this sodium chloride can restore the volume, circulating volume, and improves kidney perfusion, and it helps lower glucose level. After that, we will administer insulin glargine subcutaneous 20 units, and in HHS the patient will always have infection. Therefore, it is important to administer antibiotics. Since there is loss in electrolyte, it is important to monitor potassium and sodium. Thank you for listening.